Hello, and welcome to Grand Rounds of the Minnesota Regional Spinal Cord Injury Model Systems, or we call it SCIMS for short. Thanks for joining us today. So SCIMS is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, or NIDLR, the Spinal Cord Injury Model Systems program. Now, the purpose of the SCIMS for short is to support innovative projects and research in the delivery, demonstration, and evaluation of medical, rehabilitation, vocational, and other services to meet the needs of people with spinal cord injury. Next slide. SCIMS represents an exciting partnership among the following Minnesota institutions: Courage Kenny Rehab Institute in Minneapolis, Mayo Clinic in Rochester, Regions Hospital in St. Paul, and the University of Minnesota in Minneapolis. Next slide, please. Our community collaborators include Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up to Stand Up to Cure Paralysis, Paralyzed Veterans of America, United Spinal Association, and the North American Spinal Cord Injury Consortium. This system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency medical, acute care, acute rehab, and post-acute services. My name is Dr. Angela Hanks-Philippus, and I will be the moderator of today's session. I am a research professional in the Department of Rehab Med at the University of Minnesota Medical School. Next slide, please.
And a postdoctoral fellow.
Oh, and a postdoctoral fellow. Thanks. I'm brand new, so I'm learning this. A few housekeeping notes. The University of Minnesota has organized the CME for today's webinar. Please see the chat for information on how to record your attendance and claim CME credit for attending this webinar within 24 hours of the event. The meeting is being recorded and will be posted on the SCIMS website. To earn CME credit for today's presentation, please click on the link in the chat. And due to the number of registrants for today's webinar, we've placed phone lines on mute to reduce audio feedback. However, we do welcome and encourage audience participation using the Q&A function. If you have technical or logistical questions, we ask that you please submit those to the chat to Dan Kelly. And we extend a huge thanks to those who work behind the scenes to make these webinars possible. Next slide, please. The title for today's presentation is Advancing Care and Research, Progress and Updates from the Minnesota Regional Spinal Cord Injury Model System. And the speaker for today's webinar is Dr. Kimberly Monden. So Dr. Kimberly Monden is a tenured associate professor, licensed psychologist, director of the Division of Research and Innovation, and vice chair of research in the Department of Rehab Medicine at the University of Minnesota Medical School, with experience in spinal cord injury, clinical care, and research. Dr. Monden's research focuses on psychosocial adaptation to injury, including resilience and injustice appraisals. She is interested in improving quality of life and long-term psychosocial outcomes after spinal cord injury. Dr. Monden also has expertise in dissemination and implementation science, and she's the founder and director of the Spinal Cord Injury Psychosocial Outcome and Wellbeing Research, or SciPower for short, laboratory. Dr. Monden is the project director of the inaugural Minnesota Regional Spinal Cord Injury Model System, and she has funding from NIDLR, Department of Defense, and the Craig H. Nielsen Foundation. Dr. Monden is a fellow of the American Psychological Association. It's my pleasure to welcome my mentor, Dr. Kimberly Monden. Thanks for presenting.
Thank you, Angie. And I realized I left the Health Partners logo on here from the from the template, but I actually work for the University of Minnesota, not Health Partners. Thank you for the introduction. I have no disclosures for today. And as Angie mentioned, I'll be giving an overview of our progress in the spinal cord injury model system over the last few years. And I'm not sure how many people on Grand Rounds today are familiar with the spinal cord injury model systems in general. So I'll start with a brief explanation of what the model system is and why it's so important. So the spinal cord injury model system, or SCIMS as we call it for short, is a nationally recognized program that plays a crucial role in advancing spinal cord injury research, rehabilitation, and community integration. The SCIMS program is sponsored by the National Institute on Disability, Independent Living, and Rehabilitation Research, or NIDLR, under the Administration for Community Living at the U.S. Department of Health and Human Services. This funding supports innovative research and projects that improve the medical, rehabilitation, vocational, and social services available to individuals with spinal cord injuries. NIDLR awards SCI model systems grants to institutions that are leaders in SCI research and patient care. So these SCIMS centers provide the highest level of specialty services from acute injury management through long-term rehabilitation and successful community reintegration. Currently, there are 18 funded SCIMS centers across the United States, each contributing to cutting-edge research and best practices in SCI care. Each SCIMS center collects and contributes data to the National Statistical Center, engages in independent and collaborative research, and provides valuable resources and education for individuals with spinal cord injuries, their families and caregivers, healthcare professionals, and the general public. So the SCIMS program is really a cornerstone of SCI research and rehabilitation in the United States, ensuring that individuals with SCI receive evidence-based care and support after traumatic spinal cord injury. For those of us who are more visual, this is a visual representation of all the spinal cord injury model systems across the United States. And so as you can see over here, we really kind of filled a gap in the northern part of the country when we are awarded the model systems grant back in 2021. So a little bit more about the model systems national database that I just mentioned. So this model systems national database was established in 1973, and it captures data from an estimated 6% of new traumatic spinal cord injury cases in the United States each year. So since the inception of the model systems in 1973, there have been 32 federally funded model system centers that have contributed data to the national database. As of June 2022, the database contained information on 51,000 persons with spinal cord injuries, and it's the world's largest and longest active SCI research database. It's also the world's most extensive source of available information about the characteristics and life course of individuals with traumatic SCI. And to assure comparability of data, rigid scientific criteria have been established for the collection, management, and analysis of information entered into the database. And I will not go into all of those details today, but you can always visit the National Statistical Center's website, which is here. We call it NSCIS, NSCISCS. It's also awarded through a grant, and UAB, University of Alabama at Birmingham, has held the National Data Center as long as I can remember, so for quite some time. But if you go to that website, you can learn more about the data center, and it's also where you can download a public version of the data set if you're interested in doing research. So this is an overview of our model system, the Minnesota Regional Spinal Cord Injury Model System, or MINSCIMS. And this shows our system of care flowing from acute to outpatient care. So patients enter our system at one of 4 level 1 or level 2 trauma centers, including Mayo, Hennepin County, Regions, and M Health Fairview or University of Minnesota. And our inpatient rehabilitation centers include the Mayo Clinic, Courage County Rehab Institute, Regions Hospital, and our acute rehab unit at the University of Minnesota. And across our centers, we offer outpatient services, including outpatient therapy, vocational rehab, independent living, adaptive fitness, assistive technology, therapeutic recreation, and all sorts of other outpatient services. So this slide presents an overview of the governance structure of our MINSCIMS. The governance model is designed to ensure effective collaboration, strategic oversight, and meaningful engagement across all of the institutions in our model systems and our community partners. We're a little unique in that we're made up of 4 separate centers. Most model systems across the US, those 18 other centers, typically there might be an academic hospital and 1 freestanding rehab hospital. Many of them are just the rehab hospital. I think we are the the only model system that is 4 centers in one. So we're a little unique, and it just requires a little more organization and structure in place to make sure that we run smoothly. So at the top level, we have our core institutional partners, as I mentioned, Kenny, Regions, Mayo, and the University of Minnesota. And together, we drive the mission of the model system and support its research, clinical care, and community engagement efforts. So the governance structure is led by an executive committee, which provides oversight, sets priorities, and ensures that our initiatives align with the needs of the spinal cord injury community and make sure that we're hitting our milestones that we said we would hit in our grant application. So the executive committee is comprised of myself and my collaborators, so the site PIs and some site co-investigators from each of these 4 MnSCIMS centers. So under the executive committee, we then have 4 other committees. So we have a clinical care committee, and this committee is focused on improving clinical practices, ensuring high quality patient care, and integrating best practices into rehab and long-term management of spinal cord injury. The committee was very active in the beginning. There was a bit of a lull, and we're starting to get that committee thanks to our collaborators at Regions. We're getting that committee back on track and meeting regularly again. We have a very active community advisory board, which is a critical component of our governance structure and of our model systems. And this board ensures that the voices of individuals with lived experience, caregivers, and community members are incorporated into decision-making and research priorities. We also have a communications committee, and this group manages outreach efforts, disseminates findings, and promotes engagement with the community, including healthcare providers, researchers, and the broader SCI community, primarily through our MnSCIMS website, which I've been managing along with Abby Stromquist at Regions. And then we also have a data management committee responsible for overseeing data collection, quality assurance, and analysis, and ensuring that our research findings are robust and impactful. So together, these components ensure that our model system operates efficiently, maintains strong community engagement, and continues to advance spinal cord injury research, care, and practice. These are the core activities of the MnSCIMS. So our program engages in 4 primary areas of activity, each playing a critical role in advancing spinal cord injury research, care, and knowledge dissemination. So the first, as I mentioned, is our contribution to the national database. As part of the model system, we contribute to the national database, and this data helps researchers across the country track long-term outcomes, identify trends, and improve care for individuals with spinal cord injuries. We also have a site-specific project. So each model system site conducts its own research project tailored to address unique challenges in SCI rehab and care. And our site-specific project right now focuses on the use of Briviact to treat neuropathic pain after spinal cord injury. But I'll talk a little bit more about what a site-specific project means in a few slides. We also have what are called module projects, and I'll talk a little bit more in depth about that as well. But these projects are ones where we collaborate with other model system centers. And these studies are a little more broad in scope than a site-specific study. And then we're also focused on dissemination and education. So a key component of our work is translating research into practice. And we hope to do this through educational initiatives, publications, community outreach, professional training, and we hope to ensure that our findings have a broad reach to healthcare providers, individuals with spinal cord injuries, their families, and people at various different target audiences. So as part of the model systems, we have to enroll at least 30 participants a year into the national database. So each center has to enroll at least 30 participants. Most centers exceed this goal. We are also exceeding this goal, which is fantastic news. So since we started enrolling in 2022, we've enrolled 163 participants to date. The National Data Center says that we have to enroll at least 80% of all patients who are eligible, who meet the criteria to be enrolled in the model system. And our current consent rate is 82%. And this slide just shows the breakdown of where our participants are coming from. So the majority of our participants are enrolled through Courage Kenny, an equal amount at Mayo and Regions. And then the University of Minnesota does not have a high traumatic SCI caseload. And so we are contributing a small number to the national database. But I will say in the organizational structure, the University of Minnesota does a lot of work with the National Data Center. So Wen is our data person who ensures that all of the data are entered correctly, does the quality checks, and makes sure that we're sending all of the data in the correct format to the National Data Center, which is a pretty heavy lift. So as I mentioned, I talk a little more in depth about what a site-specific project means and what a module project means. So when I came to be involved in model systems several years ago, the jargon is a lot. And so I hope that some of these slides will help demystify some of that jargon. So while each SCIMS center contributes to the national database, we also must participate in site-specific and module studies. So this is in the grant proposal, it says that we must do this. So a site-specific project is a research study that is unique to an individual model system center, to a site. So to our 4 sites, because we are one model system center. So each funded center is required to conduct a site-specific project as part of the grant, which allows us to focus on a particular area of SCI research that aligns with our expertise, our patient population, and our institutional strength. So site-specific projects typically explore interventions, treatment strategies, rehabilitation outcomes, or new technologies aimed at improving the lives of individuals with spinal cord injury. And the site-specific project allows sites to lead innovation in a focused area of SCI research. And findings from these studies are often used as pilot data for larger multi-site trials, or sometimes will influence clinical practice guidelines. Then we have to collaborate and conduct module projects. And these are collaborative research initiatives that involve multiple SCIMS centers working together on a specific SCI related topic. So unlike a site-specific project, which is unique to an individual center, a module project is designed to generate larger scale, generalizable findings by leveraging data and expertise across the multiple SCIMS centers across the United States. So at least 2 or more SCIMS centers work together on a research study, allowing for a larger, more diverse sample than a single site project. Module projects typically go beyond routine data collection by investigating new topics that are not already covered in our standard data collection or follow-up data collection forms that we use. So each center is expected to participate in at least one module project during the grant cycle. And the collaborative nature of these module projects is what allows SCIMS to answer broader system-wide research questions that no single center could really address on their own. So I just mentioned in the last slide that as part of the grant application, it says that we must participate in one module, although I feel like that might not be correct. I feel like it might be 2. Anyways, we're involved in 7, including running our own, which makes 8. So we have been very, very busy over the last few years collaborating with all these different sites. The upside of that is that it has allowed us to collaborate with a lot of different sites. And that's sort of the power of the model systems, is being able to interact with other national leaders and national researchers and build your professional connection and start to become engaged in research that's a little broader than maybe just our area of expertise. So these are the modules that we're involved in that other centers are leading. So there's one on accelerating racial and ethnic equity in rehab outcomes, understanding formal and informal financial assistance used to cope with the economic impact of spinal cord injury. There's one on equity and quality in assistive technology. There's one on spasticity. There's one on the validation of a tool to describe bowel dysfunction in inpatient rehab settings and across the first year post-injury. We're involved in a module on aging well with disability, and then another one on feasibility, reliability, and long-term prognostic capability of a scale to measure autonomic function after spinal cord injury. And I'm not going to go into the details of where all of those separate projects are at because it would be information overload, but we are hitting our targets on I would say most of these projects, and a lot of them are starting to wrap up. So now I'm going to move into our projects. So this is our site-specific project that was proposed by Dr. Battaglino and Dr. Morse when they were still at the University of Minnesota. And so they led this project. Dr. Hanks Philippus is now the PI on this study since Drs. Battaglino and Morse have moved to the University of Miami. But the site-specific project is Briviact to reduce neuropathic pain in chronic SCI, a randomized double-blind placebo-controlled clinical trial which is definitely a mouthful. But this project has 3 specific aims. The first is to determine whether a 7-week course of Briviact reduces severe below-level neuropathic pain in SCI. Then there's 2 exploratory aims. So one, to determine whether a 7-week course of daily Briviact increases parietal operculum brain connectivity. And the second exploratory aim is to determine whether baseline microRNA 485 levels are associated with response to Briviact treatment. So this is the design of the clinical trial. The study is a randomized double-blind placebo-controlled trial, which is the gold standard for testing treatment efficacy. So participants are randomly assigned, or were randomly assigned, to either the treatment group or placebo group, and neither the participants nor the researchers knew which group they were in until the study is completed. So one of the strengths of this study is its flexibility. So participants can choose to take part either remotely or in person, making it more accessible to individuals with spinal cord injuries who may face transportation challenges. So we recruited 40 participants with spinal cord injury and neuropathic pain to evaluate Briviact, the impact of Briviact on pain management. Participants took part in a 7-week course of Briviact with the dose gradually increasing to 100 milligrams twice a day to assess its effectiveness and tolerability. So as shown in the diagram, after screening, participants were randomized into 2 groups, one receiving the drug Briviact and the other receiving a placebo. And both groups underwent a 3-month treatment period. And we're now in the process of analyzing the data to determine the effectiveness in managing neuropathic pain. So this study represents an important step toward identifying better treatment options for neuropathic pain in individuals with spinal cord injury and addressing a critical unmet need in this population. This is just an overview of what happened at each of the study visits, from informed consent to the final 4th visit, but essentially involving blood draws, surveys, measuring neuropathic pain, and there was also optional imaging as well. So our primary outcome measure was the reduction in pain intensity assessed using the brief pain inventory. And we defined a clinically meaningful response as a 1 point or greater reduction in the brief pain inventory score. And this threshold is based on established criteria for identifying a meaningful drug response in neuropathic pain management. In terms of secondary outcomes, we also evaluated several outcomes to understand the broader impact of the use of Briviact. So these included mood and satisfaction with life. So since chronic pain is closely linked to emotional well-being, we also wanted to examine changes in mood and overall life satisfaction or quality of life. We also looked at community integration, so assessing how pain relief may improve social participation and quality of life. And then brain resting state functional connectivity, so using neuroimaging techniques to analyze changes in brain activity to better understand how the treatment affects neural pathways involved in brain processing. And then finally, also exploring biological markers related to pain mechanisms by measuring changes in microRNA 485, which may provide insights into the underlying biological effects of Briviact. So I'm pleased to share that our clinical trial is now complete and data analysis is underway. Drs. Battaglino and Morse are conducting the data analysis. In total, we enrolled 44 participants, Out of those, 40 completed the trial and provided complete data for analysis. There were 2 participants who withdrew from the study, one due to receiving a spinal cord stimulator implant, which was an exclusion criteria, and another who was unable to tolerate the medication. In addition to that, 2 participants were deemed ineligible after providing consent, meaning they were unable to continue the study. So with data, as I mentioned, with data collection complete, Doctors Bataclino and Morse are now in the process of analyzing the results, which will help us determine the efficacy of Briviact in managing neuropathic pain in spinal cord injury. And we look forward to sharing our findings soon. And I want to say that this trial took a significant amount of effort from our study team. So I do want to acknowledge the contributions of not only the participants who took part in the research, but also our research team, including Tiffany, Angie, Wen, and Brian, who's no longer at the University of Minnesota, but still put in a lot of time to make this study a success. So thank you to all of you. So now I'll move on to our module project. And this project focuses on health and psychosocial outcomes associated with meeting the spinal cord injury physical activity guidelines. So the overall objective of this study is to better understand the role of physical activity in improving long-term health outcomes for individuals with spinal cord injuries. So physical activity guidelines for individuals with SCI were first developed in 2011 and later revised in 2018. And these guidelines focus on improving physical fitness and cardiometabolic health in adults with SCI, outlining recommended levels of exercise to promote overall well-being. However, despite the existence of these guidelines, a significant gap remains. So no study to date has demonstrated the health benefits of meeting these guidelines specifically compared to not meeting them. So without this evidence, it's really difficult to determine the true impact of if these recommendations do actually have a benefit on long-term health outcomes. So this research gap underscores the need for studies that evaluate whether following the physical activity guidelines leads to tangible improvements in health, quality of life, and other psychosocial outcomes for individuals with spinal cord injuries. So some people might be wondering, what are these guidelines? Why are they different than those for the general population? So these are the scientific guidelines. They're called multiple things in the literature: scientific guidelines, exercise guidelines, and physical activity guidelines. They're all one and the same. They use different terms based on different audiences. But essentially, the guidelines say that for respiratory fitness and muscle strength benefits, adults with spinal cord injury should engage in at least 20 minutes of moderate to vigorous intensity aerobic activity and 3 sets of strength training exercises for each major functioning muscle group at moderate to vigorous intensity 2 times a week. And for cardiometabolic health, this increases to 30 minutes a week of moderate to vigorous intensity aerobic exercise. And that's really what our study is focused on, is meeting the cardiometabolic guideline of 90 minutes of moderate to vigorous physical activity per week, which is lower than the guideline for the general population, which is 150 minutes. So the spinal cord injury model system's longitudinal follow-up provides an ideal setting to address this research problem. So I mentioned that we contribute to this national database. We do that when people are acutely injured. We collect data, we abstract information from their medical chart, then we follow up 1 year post-injury, 5 years post-injury, and every 5 years thereafter. So this module is built off of the infrastructure for Form 2, which is what we call those follow-up time points. So it could be 1, 5, 10, 15, 30 years after injury. It could be any time after injury, starting at 1 year. So through the model systems framework, we have access, like I said, to long-term data on individuals with SCI, allowing us to examine these health and psychosocial outcomes in a real-world setting. So to help us understand the impact of physical activity, we propose this module with the primary goal to determine whether meeting the spinal cord injury physical activity guidelines is associated with improved self-reported health-related and psychosocial outcomes. And we hope that this study will provide crucial evidence on whether adherence to the guideline leads to tangible benefits informing clinical recommendations, rehab practices, and future updates to SCI-specific exercise guidelines. So we have 3 primary aims, and those are to determine if meeting the physical activity guideline for cardiometabolic health is associated with positive health-related outcomes, positive psychosocial outcomes, and greater social and occupational integration. So I'll be focusing on the first 2 today. We haven't really delved into the social and occupational outcome data yet. We are still in the process of data collection. We're nearly complete, but not quite. And I do want to emphasize again that these are self-reported outcomes as well as self-reported physical activity. So we don't have actigraphs on anybody. We're just giving them a questionnaire to gather how many minutes per week they're getting of physical activity. So we are collaborating with 4 other centers, the Northwest Ohio Regional Spinal Cord Injury System, which is Case Western Reserve University, National Capital Spinal Cord Injury System, which is MedStar National Rehab Hospital in DC, the South Florida Model System, which is the Miami Miller School of Medicine, and then Pittsburgh, which is at the University of Pittsburgh, and then us. So we propose to enroll 350 participants, and so far we have enrolled 297. So we're 85% complete in our data collection. This is how it breaks down by site. So all sites are doing a great job at enrolling in this module. We've presented some of the preliminary findings. Angie presented some at ASCIP, I believe, in an oral presentation back in the fall, and then I just presented a poster at Rehab Psych in February. So far as sample characteristics, I won't read through all of these, but this is what it looks like. So as I kind of glance at some of these, it looks like we're pretty much in line with what the spinal cord injury population typically looks like in general. So for example, 70% male, about 30% female, that's pretty typical. We have 43% people with paraplegia, 57 with tetraplegia, and you can see how the other things break down there. About 49 years old is the average age, with about 11 years post-injury. So to address our research question, we're conducting an observational study, meaning we're just giving surveys and asking questions of adults with spinal cord injuries who have been injured for more than 1 year. So as I mentioned, this study includes data from 5 model system centers, and we collect self-reported physical activities and health and psychosocial measures at those follow-up time points. We assess physical activity using the Leisure Time Physical Activity Questionnaire, which is a validated tool that captures self-reported engagement in leisure time physical activity. For analysis, we dichotomize the physical activity on whether individuals meet or do not meet the SCI physical activity guidelines for cardiometabolic health. So meeting the guideline is defined as engaging in greater than or equal to 90 minutes per week of moderate to vigorous physical activity, and those reporting less than 90 minutes per week are categorized as not meeting the physical activity guidelines. And our primary outcomes come from the Form 2 follow-up. So these are standard questions asked of everybody in the model system. So our primary outcomes are the number of hospitalizations in the prior year and self-perceived health status. And our secondary outcomes include psychosocial factors such as mood, quality of life, and then we also have those social integration factors as well, and we haven't delved into those yet just because the way those data are collected require a lot of cleaning, and so we want to wait till the final, we have all of the data collected before we delve into that. So as far as our preliminary findings, these preliminary findings are reported on 236 participants, a little fewer than we have collected now. So we have to get this data from the data center. We can't constantly ask them for the most updated data set, or they would be very mad at us. So we ask for it probably about quarterly, I would say, so that we can update our preliminary findings. And what we've found so far is that overall, the sample reports a very wide spread of the number of minutes of moderate to vigorous physical activity per week, with a median of 15 minutes in an interquartile range from 0 to 64. So that's a pretty wide spread. We also found that only 21% of participants in our sample currently meet the guidelines, and 79% do not meet the guidelines. So that's 90 minutes of physical activity, moderate to vigorous physical activity per week. And of those people who meet the guidelines, they reported a median of 200 moderate to vigorous minutes of activity a week. So those who are exercising are doing a lot of exercise. That's quite a bit, even for the general population. So that's really good to see that those who are exercising are doing a very good job at it. However, for the 60% of those not meeting the guidelines reported 0 minutes of moderate to vigorous physical activity a week, and 40% reported some physical activity per week, but less than the guidelines, with an average of 37 minutes of moderate to vigorous physical activity per week. So 60% of those 80%, 79% not meeting the guidelines are getting 0 minutes, which is not great. What is somewhat promising is that there are 40% of people who are getting some minutes. And so that means that that's a really great group that we could potentially look at characteristics and how do we target this group to help get them to the guidelines that hopefully are beneficial for physical and health benefit, or physical and psychological benefits. So what have we determined so far? In terms of demographic and injury characteristics, we looked at associations with those characteristics and meeting the guidelines or not meeting the guidelines. And the only demographic factor associated with meeting the guidelines was ethnicity, such that people who identified as Hispanic actually had a 3 times greater odds of meeting the guidelines. And the only injury-related characteristic associated with meeting the guidelines was mobility. So compared to those who use a manual wheelchair, those who use a power chair are 69% less likely to meet the guidelines. And compared to those who ambulate, those who use a power wheelchair are 71% less likely to meet the guidelines. So nothing super surprising there. That's not really anything we don't know. Ethnicity is a little surprising. That I haven't seen that in the literature before. So we'll see how that kind of shakes out as we collect the rest of the data in the sample. There was something else I was going, as I was putting this together, I noticed that we had paraplegia and tetraplegia, but we didn't have complete or incomplete. So next time we pull the data, we will be collecting that. We will be asking the data center to send Asia impairment scores so that we can look at complete versus incomplete as well. These are the factors. So in terms of the association with psychosocial sports, so in terms of factors associated with meeting the guidelines, as far as psychosocial characteristics, sports participation was the only psychosocial factor associated with meeting the guidelines. When we did the first round of preliminary data, mood was also in there, but that has fallen out now that we have more participants, such that those who reported more depressive symptoms were less likely to meet the guidelines, but that association isn't showing up anymore. With regard to health factors, neither hospitalizations in the prior year nor self-reported or self-perceived health status significantly predicted meeting the guidelines. So to summarize what we know so far after taking an initial dive into the data, we know that 21% of our sample reported meeting the guidelines, and that this is lower than statistics on the general US population, where about 47% of the people meet the general guidelines for the US population. Our sample also seems to be a little more sedentary than other SCI samples, where it's been found that about 50% of people do not engage in any physical activity, whereas in our sample, 60% reported not engaging in any physical activity. But now that I think about it, that was 60% of the 80%, so I need to figure that out. Of those not meeting the guidelines, 40% are within 30 to 50 minutes a week of meeting them. So as I mentioned, this group represents a prime target for intervention to boost their current activity. And it appears that demographic characteristics may have little to do with whether a person meets the guideline or not, which means that regardless of sex, age, marital status, education, income, employment, or time of injury, people can meet the guideline. With the exception of race, such as those who are Hispanic in our sample, currently are more likely to meet the guidelines than those who are not. Some of our data are a little contrary to the data for the general US population, where it's typical, where we see that men are typically more likely to meet the guidelines than women. We didn't find that in our sample. Typically there's an association with income. We also did not find that. Differences, however, were found in terms of mobility, as I mentioned. So it may be that meeting the guidelines obviously is harder for individuals with higher level injuries, maybe not as much voluntary control over their muscles, which supports the need for assisted adaptive exercise programs and definitely funding for them, as we all know. We were surprised that none of the health indicators were associated with whether the guidelines were met or not. Specifically, people hospitalized in the prior year and those with poor self-perceived health status did not differ on meeting the guidelines from those not hospitalized or those with good self-reported health status. So it's important to note that the comparisons in this very preliminary analysis were all unadjusted, meaning we didn't adjust for factors that we know are related with physical activity to sort of balance out the analysis. This was just like a very bare bones basic analysis. So once we get the full data, we'll dive in a little more of a sophisticated way. So this is a pretty like high level overview. It's also important to note that our sample appears to be slightly different from the general SCI population in that they report higher depressive symptoms and lower quality of life. But nonetheless, we think this is an exciting first look at the data, and we look forward to bringing you our final results sometime in 2026. And with that, I will open it up to any questions.
Great. Thanks for the presentation, Kim. This was a good way to distill something that is very, very complicated, the model systems, and you were able to bring it all together for us. So like Kim asked, does anybody have any questions that you'd like to type in the Q&A box? Hearing or seeing none. Oh, something just popped up. Let's see. Oh, Dr. Balzer, regarding the fitness requirements study, did you prospectively collect data on the barriers and methods they used to exercise?
We did not collect anything on barriers. Angie, in the Leisure Time Physical Activity questionnaire, it doesn't ask methods, right?
That is correct.
Yeah, so we do not have information on barriers. I do feel like, didn't we have something on like sports participation?
Yes. So we
I
have
feel like there's,
yeah.
go for it.
Yeah, there's other questionnaires that we tagged on besides the Leisure Time Physical Activity questionnaire, and I got into more of how do you spend your time doing physical activity. So we could look at item by item, like swimming, wheeling, and like Kim mentioned, sports participation, things like that. So once we finish data collection, I imagine we'll start looking at it in a more granular way like that. That's a great question.
And I do want to emphasize the nature of the collaborative nature of the model system. So if there is something that piqued your interest today, please reach out to me, and happy to include folks. Obviously, those who are site PIs and co-Is will obviously be included, but we have a lot of institutional knowledge about the model systems. And when I say we, I actually mean Angie, who served as a data collector for the TBI model systems for about a decade. So as I mentioned, there's a free version of the data set that you can get from the data center. And so if anyone wants to use the data set for some sort of analysis, feel free to reach out, and we can always help you with an analysis and kind of guide you through some of the idiosyncrasies of the the database.
Yeah. We have another question here. Are there any community financial resources for gym membership or patients with spinal cord injury?
I know Courage Kenny has a program, but I can't speak to the specifics, and I don't know if anyone from Courage Kenny is on. But Parisa, I can put you in touch with Carrie Sjogren, who could give you more information on that. I think they have a scholarship for the ABLE program.
Good question. Others?
I do want to mention too, a lot of times these, thank you, Carrie. She said we do have a cost share and scholarship option. I do want to mention these module projects. So you're only allowed, when you write a model systems grant, I mean, you could budget for more, but it's a pretty slim budget to begin with. But you have to budget at least 15% of your budget towards these modules. So that includes your module plus having to participate in another person's module. And so it would have been lovely to be able to put like actigraphs or some objective measure of physical activity to give those to our participants so we could track that along with the self-report data. And unfortunately, it just wasn't feasible within the budget. But I know Kathleen Martin Guinness and Jasmine Ma up in British Columbia have been doing some of that work of like which actigraphs and physical activity monitors are best for people who use wheelchairs. And I think looking at the association with self-reported physical activity.
That'll be helpful information when that comes out, definitely.
Yeah.
It looks like Andrew also said, Get Up, Stand Up for Paralysis. GUSU offers scholarships for adaptive fitness as well, which is great to know. And he put a link in the Q&A for folks who'd like to use that.
You want to leave that up there?
Mm-hmm.
Thank you.
Well, if there are no more questions, or if there are questions afterwards, you can always email Kim and I'm sure she'll get back to you promptly. But
maybe not promptly.
She'll get back to you.
Don't promise promptly.
But thank you all for attending today's grand rounds. And again, we apologize if your questions weren't answered, if you're still thinking about them, but do feel free to reach out to Kim directly if you want some follow-ups. This recording for the webinar will be posted soon on the SCIMS website with a link to our YouTube channel. And as a reminder, please see the chat information on how to obtain CME credit for attending today's webinar. At the end of the webinar, a brief 3-question survey will pop up. We'd really appreciate your feedback. So thank you all so much. Oh, Amanda has her hand raised. She just...
Sorry, that was an accident.
Excellent. Well, thank you, everyone. Have a great rest of your day.